Okay, so we're going to ask the LAO to begin with a summary of the Special Master's report.
Thank you, Madam Chair and members. Sarah Larson with the Legislative Analyst's Office. So to begin with, there are 6 programs currently that provide inpatient mental health care to Coleman class patients. 2 of the 6 programs are run exclusively by the California Department of State Hospitals and treat both Coleman and non-Coleman patients. And these programs for CDCR inmates are at Atascadero State Hospital and Coalinga State Hospital. 3 of the programs are co-located on prison grounds, and DSH is responsible for clinical services. These are the Vacaville Psychiatric Program, which is on the grounds of the California Medical Facility, the Salinas Valley Psychiatric Program, which is at the Salinas Valley State Prison, and the Mental Health Inpatient Program at the California Healthcare Facility in Stockton. The last program is the Psychiatric Inpatient Program at the California Institution for Women, the CIW-PIP program. And in that program, CDCR provides inpatient mental health care for female CDCR inmates. In July of 2013, the Coleman Court ordered the special master in the court to monitor all 6 programs and to report to the court on his findings. The special master's report raised several issues, including the level of clinical staffing, the quality and quantity of treatment provided, and access to treatment. One of the overarching themes of the report was that the programs vary widely in the policies and practices in all areas of administration and delivery. In the area of staffing, the special master noted that inadequate staffing posed a barrier to effective care. For example, he noted that Atascadero State Hospital had a vacancy rate of 61% for psychiatrists. According to the special master, the lack of necessary psychiatric staff limited the effectiveness of treatment, given the importance of psychiatrists in treating people with severe mental illnesses. The special master also noted that a high use of registry staff led to instability in patient care, and that even when registry staff were used, the department did not achieve appropriate staff-to-patient ratios. The special master did note, however, that the CIW-PIP program had all of its psychiatry and psychology positions filled, and that overall clinical staffing levels in the program were adequate. With regards to the quality and quantity of treatment services provided, the special master found that as a result of the shortage of psychiatrists, treatment team meetings did not sufficiently address the role of medication or psychiatry in treatment. He also noted that treatment plans were often not sufficiently individualized or responsive to patients' specific needs. When looking at direct programming, the special master noted that some programs heavily relied on group therapy as opposed to individual therapy. For example, the report notes that at Coalinga State Hospital, the only individual therapy that was provided was as providers were passing patients in the hallways. This is problematic as some individuals may not be ready for group therapy or it may be contraindicated. The report also noted that even the amount of group therapy that was offered was often insufficient. At Atascadero, for example, patients attended an average of 4.6 hours of group therapy per week. Additionally, at Salinas Valley, patients were attending groups based on location rather than on their specific treatment needs. At Vacaville, patients were scheduled for widely variable amounts of group therapy, anywhere from 1 to 36 hours, and even activities such as exchanging magazines was considered group therapy. The special master also raised concerns about the treatment of condemned inmates, which occurs at the Vacaville Psychiatric Program. The report noted that those patients received far less treatment than other patients at the same level of care and did not have private meetings with their providers or access to appropriate group therapy. The report did note that the level of staffing and specialized treatment on the enhanced treatment unit at Atascadero was sufficient and that the results of that particular program were promising. The report also noted that the CIW-PIP program was providing adequate levels of care, including individual and group treatment, and that custody did not pose a barrier to care at that program. The special master's report also noted that there was wide variability in access to care in the programs, including with the use of cuffs, restrictions on newly admitted patients, how patients progressed through various levels of treatment, and how patients were disciplined. The special master recommended that the programs should focus more on individuals' risks and that restrictions and staging should be based on individual patients' conditions. and perhaps a reconsideration of the trade-off between the need for security in the facilities, because these are very high security inmates, along with individualized patient treatment needs. According to the special master, and this is a quote from the report, it does not make sense to remove these patients from a prison environment where they're receiving treatment and subject them to less therapeutic conditions than those in prisons. Based on the concerns identified in his report, the special master provided 3 main recommendations. The first is that he recommended further review of the 6 programs. He noted that the CIW PIP program and Coalinga State Hospital could probably be subject to a paper review, but recommended on-site monitoring at Atascadero, Stockton, Salinas Valley, and Vacaville. He also recommended that CDCR and the Department of State Hospitals review their use of cuffs on patients, as well as the process by which patients progress through various levels of treatment, and whether the policies related to those issues strike the right balance between safety and the quality of care. Finally, he recommended that CDCR and DSH be ordered to review and reevaluate clinical staffing levels, how those staffing levels affect the quality of treatment in the programs, and whether a plan needed to be developed to adjust staffing to ensure quality of care. I believe the department has updates to provide to the committee related to those recommendations, as well as the services provided in those programs, and I'd be happy to answer any questions that you have.
Okay, thank you very much. Yes, we would like to hear the department's response to the...
Good morning, Madam Chair, members of the committee. Thank you for taking time to hear us today. I want to thank Ms. Larson. She actually touched on most of the topics of the status update that I believe was provided to you in advance. So I'll kind of speak to those specifically where there were items of improvement noted, and then I'll go into the questions themselves on the agenda. One topic of discussion is the staffing ratios, and so we're both currently looking at staffing ratios and continuing to recruit and retain, but there also is an outstanding order for the special master to additionally work with the department on the evaluation of appropriate staffing levels. So that is still a work in progress that we are consulting with the special master on. So speaking towards the summary of improvement measures implemented across all the programs as a result of the reviews, and specifically at the time of the reviews, we held exit conferences at each facility to get the initial insight of the monitoring members as well as our own staff. There were a variety of measures that were brought forward at the exit conferences. So some of the significant system improvements that we've made in the last couple of years have been focused on implementation of a specific recruitment and retention section of our department, specifically to reach out to those hard to recruit and hard to retain clinical classifications. The recruitment unit, we've cast a very wide net now beyond the local areas of California. We've gone out additional states, statewide, nationwide, in attending recruitment events, establishing a streamlined hiring and recruitment process for clinical staff, so that when we have those candidates that are looking to come into our system, we can very clearly and very cleanly walk them through the hiring and credentialing process and get those clinicians on the ground as soon as possible. We've worked very diligently to increase the quantity and the quality of the treatment that the patients receive within the institutions. As noted in the Special Master's report, there were various numbers of estimated treatment time per week that patients were receiving. One of our gaps at that time was the ability to effectively track and document what treatment was occurring. So we have implemented new software systems that track the group hours that the patients attend, the individual treatment, leisure activities, both structured and unstructured. So we've developed those reports in coordination with the special master during the visiting rounds, and also in collaboration between visiting on reporting for future visits. In relation to the orientation and cuff status, we worked very closely with our partners at the CDCR in the evaluation and the use of the cuff status, the discretionary program status, that are behaviorally based changes to a patient's ability to program. And we were very pleased to hear in the January exit, the special master commended us on a significant reduction in the use of cuffs in those areas. Salinas Valley was one of the initial facilities that was toured by the special master, and the cuff status process itself was of grave concern. We put a variety of mechanisms in place there to both establish appropriate use of the cuff status, appropriate auditing and tracking, and ensuring that there's sufficient process that allows the patient to be removed from that status as quickly as possible when it's clinically indicated. We continue to work on a variety of levels with corrections on the utilization management process, the inflow and outflow of patients between our systems through the continuum of care. We continue to hold a variety of work group meetings on patient case conferences, difficult to resolve or place patients, some of those difficult medical cases. We've worked also to have our medical director and myself are attending some of the DRB meetings to look at the potential transfer for some of our very high secure patients to CDCR. So we basically increased our collaboration across the board with CDCR at both the local levels at the facilities, but also at our management and executive levels here in Sacramento. A couple of things we're doing specifically related to the admissions and improving admissions. We are implementing a patient reservation and tracking system that has been developed at the state hospitals, and we are rolling that into the psychiatric programs, and that will give us a centralized data management of patients that are referred into our system so that we can very efficiently move them into the appropriate facility and make sure that that continuum of care occurs as efficiently as possible. That will also give us additional ability to report progress and status to the court and the special master. Some of the initial issues that were raised at Salinas Valley during the federal court hearings were related to supply issues in the facilities, appropriate linen, clothing, food supplies, and so on. We've instituted a significant review of the policies and practices there at Salinas Valley specifically with a interdisciplinary team working across all levels of how the supply items come in through the warehouse, how they're distributed, how they're tracked, how they're issued, and how they're audited. CDCR and PIA have been strong partners in our collaboration on reviewing those policies and procedures. We've implemented a very robust auditing and tracking process as well to ensure that those shortages don't occur in the future. One of the more significant clinical aspects of improvement that we've done is we've implemented an internal clinical oversight team, which is part of our internal Coleman monitoring group, if you will. As I think we've reported previously to the legislature, one of our key teams in our department is the Clinical Oversight Advisory Council, which is a statewide interdisciplinary team that provides clinical monitoring and clinical outreach to our state hospitals in the development and design of best practices system-wide for our enterprise. On this particular group, we actually have pulled some of those members off to be a subgroup during the monitoring rounds. We have a psychologist, a psychiatrist, a registered nurse, and a psych tech working on a variety of work groups to keep the ball rolling, if you will, on the oversight of some of these implementations. Significant ones that we're really working on is a clinical audit tool for treatment plans, in mentioning the need for patients to have individualized treatment plans, individualized care and treatment, which does equate to the amount of programming and time out of cell that they're able to manage. So we're working on providing a consistent statewide curriculum for the psychiatric programs so that the continuum of care through the psych programs, as well as going into the state hospitals in Coalinga or Atascadero, will be much more consistent across the board as patients move through our system. That will also alleviate some of the variations across programs in certain patient privileges and options available to them as they move through, which was one of the special master's concerns. The establishment of a standards compliance team is related to our data reports that the court requires. We had our most recent visit in January. They provided us a list of 16 areas they wanted specific reports and data on. We're working with that team to both continue the building what we reported in the last round, but also to provide that in a much more consistent shape and fashion for the June round. The June round is expected to come back to all of the facilities. The reporting that we will get from the special master is expected to be sometime after the culmination of both of those reports, and will be an analysis of both of their visits, documentation that's been provided, and we expect then a further report that will, in our expectation, show a vast improvement and significant resources put into the development of the programs. If you'd like, I can speak just briefly to the 3 questions that were listed, if I haven't covered
yeah.
them already.
But I was going to say, I think that you covered, all of them in terms of an overview of your
Okay.
response. My question would be, I noticed that you're referring to written notes. Could the committee have a copy of those notes? Because nobody can really take notes fast enough.
I'm sorry, I thought we had distributed that in advance.
Maybe you did. Oh, okay, we just got it.
Okay, I
Thank
apologize.
you.
Yeah. And,
Thank you very much.
and as I mentioned, Ms. Larson's report captured much of the same information that was pulled from the Special Master's report, the Coleman orders, the declarations filed with the court. I'm very happy to answer any additional questions you might have.
Well, you alluded to the discussions between DHS and CDCR on the possibility of shifting some or all of the psychiatric programs to CDCR. I think, based on the fact that it appears that the one program that CDCR does control is having better outcomes, and that's the one at the California Institution for Women. Is that correct? Or can you tell us a little bit more just about the status of those discussions? And what would that actually mean, since I don't believe CDCR has the facilities? They would have to operate the facilities, I would imagine, in the existing state hospitals.
I can answer briefly the CIW question. Okay.
If I may, Han Wang, Department of Finance. The discussions are still ongoing at this time. There are various issues such as the staffing, the cost, facilities, and possible efficiency gains. And so at this time, we have no further updates.
Okay.
Madam Chair, on that.
Yeah, Senator Bell?
My feeling on that is it's such a complicated issue that it should be dealt with in a policy discussion. Because that's a very complicated issue of just moving, and I don't even like the idea to begin with, so I think we have to have a sort of a policy discussion. The community ought to get involved. There's a lot of, we can't just deal with it as like, okay, we're going to do this. I mean, there's a lot of people that would like to have varying opinions about that, and we should, to be honest about it, I don't think, we haven't seen a proposal, and I certainly don't want to adopt one in this budget, even if
This
it
is
came up
an
in May.
oversight item, so we're
Yeah.
not taking any action.
Yeah, I know.
We're just trying to get some of the
But
issues on the table.
they're saying they're discussing it, and, they're bringing this up in the context of the budget committee. So I'm saying I don't want to bring it up in the context of the budget committee. I want to bring it up in the, the governor's got a proposal, let's get a bill on the table, let's go through our legislative process.
I think if there's ever a proposal, that was probably what would happen. Unfortunately, our legislative process turns into many, many bills to be analyzed every week, and therefore we don't often go over some of the things like the audit report and the response to it. And this is an opportunity, I think, for us to get some of those issues out on the table. I wonder if you could just address in a little more detail the concerns about how little time inmates spend out of their cells or in programming.
Yes, I can. And that kind of alludes to question number 1. And I can say that the DSH environments within the psych programs are designed to provide appropriate security and safety so that patients can be provided treatment in an environment that is both safe for patients and staff. We do not consider this to be a segregated housing unit, as the patients are continually encouraged and challenged to work and be active participants in their treatment. There are many out-of-cell opportunities for the patients, and the staff are trained to continually work with the patients on motivating them to participate in treatment. We do have many patients that have not been programming at an adequate level, and the EOP level status at CDCR are referred to us. So on an individual basis, sometimes it just takes getting that patient out to attend the dining room on a regular basis, and then attending some leisure activities. So part of what we have for each patient is an interdisciplinary clinical team that's assigned to each patient that designs a treatment program individual for that patient. And we try to build on all opportunities to have the patients come out of cell. I noted in the report the very low number that was listed in the special master's report. And currently, from our efforts to continue to increase the programming hours of availability and participation, we currently have system-wide in the 3 psychiatric programs approximately 8 to 10 hours of out-of-cell treatment occurring per week now. And I think in the special master's report, the Vacaville specifically was listing 1 to 4 hours per month. So we're seeing a significant increase in both the participation of patients in treatment, as well as our ability to document and report on the efforts that we've taken to increase those numbers.
Yeah, for me, that's the kind of follow-up reporting I'm very interested in. I'm also interested in what kind of training we're giving both the medical, clinical staff and some of the custodial staff so that they work together well.
Yeah, in our programs, which are quite unique with the use of the medical technical assistants, they are the primary custody staff
Right.
within our institutions, but they're also nursing staff. So we utilize them also both for a nursing component, patient care, patient teaching, patient assistance with daily living needs, as well as being a component of the treatment teams and the group facilitators when those are occurring. So we develop curriculum. One of the things that we do have, the work group, is the statewide curriculum committee, which is continuing to revise and improve the curriculum that's available and that is trained to the patients during their treatment, both group and individual. So our statewide clinical operations advisory council assists in developing that curriculum. It's patient-centered. It provides appropriate interventions for the specific needs that the patients have, and then the staff receive training on how to provide that training, how to provide those group treatment hours, as well as ensuring that they can track and document in the patient's treatment plan how effective the patients are, so that interventions can occur over time when they find one particular treatment or another is not effective. An additional aspect of the training that we're doing now in the auditing is the quality of the treatment team, which is really the living document that designs what that patient needs to be successful in transferring back out into their community, which is the CDCR environment. And those treatment plans, we're doing continual training with our staff on the quality and the conciseness of those treatment plans, as well as auditing periodically across all of our programs to ensure that the quality of the audits is good. And we've implemented those audits as well as that quality review in the past number of months across all the programs.
Okay. And I'm also interested in what we're really going to do about the shortage of psychiatrists. I think this is a deeper discussion. I've been kind of told off the record by various people working in the institutions that it's very, very difficult to recruit, sometimes because of the institutional culture, sometimes because of that the locations of the institutions aren't population centers for psychiatrists.
Right.
But I think we really need to have a careful look at that, or we're always going to be behind the 8 ball on that, if I could say that. Okay, I don't know if the rest of these would really be questions for DHS or for CDCR. We have the interesting situation that in CDCR, they tell us that about 45% of the inmates have been treated for a mental health problem every year, and they're not under the control of the state hospitals. It's only the people that have been remanded over. So I would simply note that I think the cost per patient, if I did my math right, which I might not have done, is about $500,000 a patient? Well, if anybody could do that math and tell me the number, I'd appreciate it.
Carla Castaneda, Department of Finance. The programs provided by the Department of State Hospitals are closer in the $210,000 range per patient. It does vary by individual, but that is the average if you take the full budget divided by the
Okay,
patients.
so it's about 210,000 per patient.
It's in here somewhere. I thought I saw it.
I tried to,
It's in there, yeah.
yeah, the zeros get confused, so don't worry about it. So it's about, but that's a lot of money and a lot of therapy that you could buy on the open market in different ways. So it's of interest to me how we spend that money and what kinds of outcomes we get. DOF, do you have any comments on the report? We've had questions from the subcommittee. Is there any public comment on this item? Yeah, please come forward to the microphone.
Everyone, good morning. My name is Colby Lenz. I'm a volunteer advocate with the California Coalition for Women Prisoners, and we've been doing advocacy work with people in California women's prisons for the last 20 years. I've been doing it for about the last 12. And recently we have more of a program with people at CIW, so we are closer in contact with people who are receiving mental health services under the Coleman class and people who are being moved between the PIP unit, the SCU, Suicide Watch, a lot of acronyms we don't always even understand what they mean, but we are here because we wanted to make sure to call attention to the fact that based on our numbers, which are based on CDCR data, CIW had the highest suicide rate in 2014 than any other California prison adjusted for population. And also based on Bureau of Justice statistic numbers, that rate, the suicide rate at CIW was 12.7 times the national average for prisoners committing suicide and 7.6 times the statewide average for California prisoners. So we did those numbers because we've been hearing report after report from people that we work with at CIW about the suicide rate, both actual deaths and attempted suicides. CIW also seems to have one of the highest attempted suicide rates last year. And it's not just a 2014 problem because already in 2015 we've had 3 people commit suicide at CIW. We have reports of 2 of those people, and we'll pass out the paperwork to you all that we have in the back corner over there. 2 of those people were moved out of Suicide Watch the day before. At least 2 of those people were asking for help, including that same day that they killed themselves, asking for mental health help and not getting it. So we're concerned that between the special masters, some of the special masters report we agree with and some of which we don't. We think there should be further review into CIW, not just a paper review. We want there to be a full investigation into the deaths in 2014 and 2015. And we have members who've been there for decades who are saying they've never seen anything like it. Including somebody that I visit with who said that she went to go borrow a pair of scissors the other day from the cops, which she's usually allowed to do, and he said, now we have to have these industrial scissors to cut down the ropes that people are using to kill themselves, so I can't lend them out to you, and he showed her the pair of scissors, and it was this huge pair of industrial scissors. So these are the reports that we're getting. We're very concerned that the messages coming through the various oversight bodies aren't representing this, and we would really appreciate if the legislature would take more action in terms of independent investigation. And then part of our ask also is always to help release some of these people who are waiting for release based on elder parole, juvenile parole. We're just seeing all of the blocks to all of this at the same time as the prisons continue to be overcrowded, even though the cap's down. So thank you, and we have other people that will speak to this too.
Actually, it seems to me this might be a segue into our next item, which is what CDCR is proposing to do. So, yeah, so thank you very much.
Thank you.
Thank you for your report. And we will move to item number 3, which is the Department of Corrections and Rehabilitation budget proposal relating to
Good morning, yes. Okay, good morning. Jason Lopez, Deputy Director of Fiscal Services for the department. I'm going to go ahead and lay out a brief overview of the proposal, and then I'll let the three individuals who are even more familiar with the proposal than I sit down and first provide an overview of each of the major components and then answer any questions that the committee might have. CDCR and the Receiver's Office request 56.9 positions and just shy of $13 million in current year, growing to 290.4 positions and almost $42 million in 15-16 and ongoing, in order to implement new programs and policies and enhance existing policies related to our mentally ill inmate population, consistent with the Coleman Court orders dated July of 2013, April 2014, and then again in August 2014. The major components of the proposal include use of force and management cell status, restricted housing, non-disciplinary segregation, inmate patient welfare check system, often referred to as Guard 1, monitoring and oversight, and specialized mental health training for both our healthcare and our custody staff. I'm going to go ahead and give up my seat and allow one of our program experts take the mic and give you an overview of the legalities of the situation. We're also joined today by Ms. Kathleen Allison, who is from our Division of Adult Institutions, and Ms. Angela Ponciano, who is from our Division of Healthcare Services.